Hi, everybody. Welcome. We'll get started in a couple minutes. Q&A is open. Feel free to hop on in there, say hi, let me know where you're from. How was your weekend? I decided to go to Chicago, so thank you so much for everyone's recommendations. I got pizza, went along the river walk, went to Navy Pier, and went to both a Cubs and White Sox game. So that was a lot of fun. So share with me in the Q&A what you did. Love to hear all about it. Hopefully it was relaxing or fun, maybe some self-care. Wouldn't that be nice? I would love to hear all about it. For anyone that doesn't know, we got the water buffalo loose in Des Moines. Anyone spotted the water buffalo if you're in Des Moines? All right, so Italy is here. Sonoma County, California, UK, Ontario. St. Louis, Missouri, moved over the weekend. That had to have been so difficult. Moving is hard in general, but for it to be so hot. Puerto Rico did lots of work. Sarasota is here, Arkansas, France, South Africa, some more Puerto Rico. Virginia did some studying over the weekend. California is here, Iowa, went to baseball league games, steak fry. Sounds like a good weekend. South Orange County, California is here, Brownsville, Pennsylvania. Creed and Pitbull concerts. That sounds like fun. Pool, went to the pool in Des Moines. Iowa City's here, Canada, Virginia Beach. New Jersey went out for breakfast. I love me some breakfast. Syracuse, New York, India. All here. Welcome. For those of you just joining us, we'll get started in just a minute. Q&A is open. Feel free to hop on in there, say hi, let me know where you're from. We're also sharing what we did over the weekend. I took all of your tips and advice and went to Chicago, ate some pizza, went on the river walk, went to Navy Pier, and saw both the Cubs and White Sox game. It was a few busy days, and I am still feeling tired. All right. Maryland is here, spent time with the dog. That's fun. Texas, time with friends and family. North Carolina is here, the Upper Peninsula of Michigan. Watched Godzilla movies. I've never seen any of that. Scotland, birthday. Happy birthday. Wisconsin, went to the Green Day concert. Brampton, Ontario is here. Arkansas. Oakland, Maine. Fort Myer, North Carolina. Des Moines is here. Missouri. Looks like people were spending time with friends and family and grilling. Concerts. Looks like lots of concerts. I'm going to tell you something, and it might be wild to hear. I've been to 3 concerts my whole life. First ever was New Kids on the Block when I was little. Next was Blink-182, and most recently, which was still probably 10 years ago, was D'Angelo. Those are the only concerts I've ever been to. Nashville's here, Atlanta, South Florida, Palm Coast, Florida, went to Dave & Buster's. Cornwall, UK, Shelby Township, Michigan, Vancouver Island, Virginia is here, Manitoba, Wesley Chapel, West Virginia, North Dakota, Georgia is here, South Carolina, Los Angeles, Vancouver, Louisiana, Wales, UK, Arizona, New Jersey. Looks like a lot of places are really hot. I'm feeling a little warm myself. Western Massachusetts, Oklahoma, Iowa, California, Oregon, Ireland, Philippines. Maryland ate some blue crabs. All right. Toronto is here, Ireland. Ontario, Bakersfield, Detroit, Las Vegas, Delaware, Cape Town, Northern Iowa went fishing. Some more Michigan, Chicago, Nova Scotia, Myrtle Beach, San Diego, Iran, more Florida, and UK. Awesome. I love it that we have people from all over. It is my favorite part. I love it. And you all know that I love being able to chat in the beginning, but it's important we stay on time, right? So I'm going to have a drink and then we'll get started. Great. So today we're going to be talking about understanding obsessive compulsive disorder, also known as OCD. And this is brought to you by Mindspring Mental Health Alliance with a special thanks to United Way of Central Iowa for partnering with us and sponsoring today's webinar. So everyone's mics are muted, your cameras are off, Q&A feature is on. If you have questions, hop on into that Q&A, send them over to me. I'll check questions as we go through each section. If you ask a question that I know I'll be able to answer through a future slide, I'm going to hold off until we get there. I'm also going to save a little time at the end for questions and answers. We're going to end 50-ish minutes. So just keep answering questions as long as time allows. Now we do have 600 people joining us right now. Usually over the next few minutes, we get a couple hundred more. And I bring that up as to why there's a chance I may not get to all of the questions. So please don't be offended or take it personally if I don't get to your question. We simply just ran out of time. Now we do have closed captioning available. Go to the bottom of your screen, look for that CC button, give it a click, and that'll turn captions on. Click it again, and it'll turn them off. And then for anyone that is new, my name is Jamie. I am a licensed master social worker. When I'm not here doing these webinars with all of you, I'm a therapist. Prior to that, I worked in housing. Before that, heavily in child welfare, working with kids and teens that had experienced some abuse or neglect, many of them being part of the foster care and adoption system. Now let's go over our frequently asked questions. This is being recorded, and everyone who registered for today's webinar will receive an email with a link to the recording in it. Also in that email will be all of the resources we talked about today. No slides will be sent out. And then everyone who registered for today's webinar and joined the live session is going to receive an email from certificates@mindspringhealth.org soon after the webinar ends. Once you complete the webinar follow-up survey, you will be sent a certificate of attendance. Now, certificates are not available for anyone who's only watching the recorded version of the webinar later on. And CEUs are not provided for community education webinars. All right, so what are we going to learn today? We're going to go over diagnostic criteria. So what criteria needs to be met for a diagnosis of obsessive compulsive disorder, how prevalent the disorder is and what causes it, as well as what increases our risk of developing it. We'll talk about the other disorders that we often see along with obsessive compulsive disorder. We'll go over the way the disorder is treated. And then we'll talk about managing symptoms. So if you yourself have OCD, what you can do in addition to treatment to reduce the frequency and severity of your symptoms. And lastly, how to help others. So if you have a loved one with OCD, what can you do to give them some help and support? All right, so first, what is it? What's OCD? So that's short for obsessive compulsive disorder, and this is a mental health disorder that affects people of all ages and walks of life and occurs when a person gets caught in a cycle of typically obsessions and compulsions. So like I said, right, OCD usually includes both the obsessions and compulsions, but it's possible to have only obsession symptoms or only compulsion symptoms. So let's talk about how this is diagnosed, and this is going to be based on the DSM-5-TR. So DSM stands for Diagnostic and Statistical Manual of Mental Disorders. It's in its 5th edition. The text revision came out in 2022. It is created by the American Psychiatric Association. In it, you'll find all of the identified mental disorders, information about each of them, and it includes the diagnostic criteria. So that way, Professionals are using the same criteria across the board for every client or patient to make that diagnosis. So to receive a diagnosis of obsessive compulsive disorder, there needs to be presence of obsessions, compulsions, or both. So first, let's define obsessions. So reoccurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance. So during, this episode of OCD. And it's intrusive and unwanted. So they aren't thoughts that we want to have. They just kind of force their way into our mind. And that they cause anxiety or stress. So they're upsetting. Next, the person attempts to ignore or suppress these thoughts, urges, or images, or to kind of neutralize them with some other thought or action. And so that action would be considered a compulsion. So now let's talk compulsions. First, repetitive behaviors, things like hand washing, ordering, checking, or mental acts, praying, counting, repeating words silently, right? And that's just a small amount of examples that the person feels driven to perform in response to an obsession or according to rules that must be applied rigidly. So oftentimes we're going to see these repetitive behaviors happening after those obsessions, those intrusive, upsetting thoughts. But it could also be that the person has specific rules that they have to follow. And so they have to wake up on an even number. So they set their alarm for an even number time. And then the behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive, right? So first, let's talk about how they're not connected in a realistic way, right? So I have to walk around the couch 3 times and then sit down, or my dog will run away. Right? So the obsession is the fear of the dog running away, causes a lot of distress because we're thinking about it often. And so our brain has decided that if we do this behavior, walking around the couch 3 times before sitting down, the dog won't run away. So that is what is meant by there's no connection that is realistic, right? Walking around the couch 3 times has no impact on whether a dog runs away or not. Or these behaviors or mental acts are clearly excessive, right? So worrying that you didn't turn off your curling iron, right? That is a realistic problem, right? If we don't unplug certain things that are hot, a fire could start, or damage to the counter or whatever, right? So it's not that this isn't realistic, but the going in and unplugging it and then walking out and going back in and maybe going in and out 5 times to ensure that it is unplugged is where it's excessive, right? So it's realistic that we have the thought the house might burn down if I don't turn off or unplug my curling iron or regular iron or straightener or whatever you want to choose, right? That is realistic. The excessive part is that I've gone back and forth 5 times or 10 times. Now, in young children, they may not be able to articulate or explain the purpose of their behaviors or mental acts, right? So here in number 2 that we're talking about, these behaviors or mental acts are aimed at preventing or reducing anxiety or distress or a dreaded event or situation. An adult would be able to describe that. Sometimes young children don't know how to describe that. The next obsessions or compulsions are time-consuming. They take up, for example, more than an hour per day. Or they're causing clinically significant distress or impairment in a variety of situations like social, occupational, or other important areas of functioning. So this means that these behaviors are upsetting, so causing that distress and getting in the way of someone to being able to fully function within various areas of their life. Maybe they struggle to get things done at work. because they need to write and delete a report 6 times. Or maybe they're struggling in a relationship because they're always late for everything because they have to clean a certain amount of times. Or sometimes they're not even able to get out the door because of all of these compulsions that need to be completed. Then the obsessive compulsive symptoms are not attributable to a physiological effect of a substance. So they're not happening strictly because someone has been using alcohol or other drugs, medications, or has another medical condition that could be causing these things. And it's not better explained by the symptoms of another disorder. So examples could be excessive worrying, like we find in generalized anxiety disorder. Preoccupation with appearance, or as we find in body dysmorphic disorder. Difficulty discarding or parting with possessions that we see in hoarding disorder. Guilty ruminations that we'd see in major depressive disorder, or repetitive patterns of behavior that we see oftentimes with autism spectrum disorder. Okay, so now that we know kind of that diagnostic criteria, it can be helpful to better understand what obsessions and compulsions are. Before we do that, let me just see if we have any questions from this last section. So can you have obsessions without compulsions, but not compulsions without obsessions? And you can have symptoms of one or the other. Most commonly, we're going to see them together. Could guilty thoughts be part of OCD? And it can be, right? But those thoughts need to be meeting the diagnostic criteria. So just simply having guilty thoughts once in a while wouldn't meet the criteria. So what if the obsessions are just that continual rumination, but there's no compulsions? So OCD can be just obsessions. It's less common, but that is possible. Can someone have autism and OCD? And they absolutely can. So what happens to someone if they're no longer able to continue with their compulsive behaviors, maybe due to ill health, right? So, or mobility, change in mobility. Oftentimes, they're going to find a different compulsion to attach to the obsessive thoughts, something that they're able to do. And that is something you can see happen throughout the disorder, that the thing that's being obsessed over or the compulsive behaviors change. All right, so let's talk about obsessions and compulsions so we can understand it a little bit better. So obsessions are thoughts that people have over and over again that can't be controlled. It's important to understand that people with OCD don't want to have obsessions. They're unpleasant and can be pretty upsetting. And people with OCD usually know that their obsessive thoughts don't make sense, but they can't stop the thoughts from happening. Now, it's common for obsessions to have themes. Sometimes these themes overlap. So it can be a fear of contamination or dirt, needing things to be carefully organized and symmetrical, thoughts about losing control and hurting themselves or someone else, moral or religious obsessions, often with concerns that they've already done something sinful or immoral. Unwanted sexual thoughts about incest, pedophilia, intrusive thoughts about being a different sexual orientation than you are or want to be. So this is not, we're not talking about people that are trans. This is someone who's having thoughts of it when they don't really want it. So it's just an intrusive thought. Or other intrusive sexual thoughts. There's obsessions about losing control, or, what we might, in air quotes, going crazy. Fear of being possessed, having a psychotic break, becoming a mass murderer. Obsessions about health and fear that you may have a serious illness or disease. People will sometimes spend hours researching symptoms, checking for symptoms, getting second, third, fourth, fifth opinions from doctors just to make sure. And so an example of how sometimes these themes overlapped could be the obsession about health with the fear of being contaminated with any kind of disease. Now, the compulsions are the thoughts or repetitive behaviors that people do to cope with the obsessions. So 2 important things to understand about compulsions. First, people with OCD understand that their rituals don't solve the problem, but without a better way to cope, they use the compulsions to manage these really unpleasant thoughts and feelings. Compulsions are time-consuming for people who experience them. They're not able to do a lot of the things that they really want to do because they're spending so much time doing compulsive actions. An example of this, like I mentioned, canceling plans because you need to keep up with your cleaning schedule, that is excessive, right? All of us need to clean our space. Sometimes we can't go do the things we want to do because we need to clean it, but this is more about having to spray down and wipe the kitchen table 14 times for it to be clean, right? So we're not talking about just the regular things that we need to do throughout our living in a space. We're talking about being excessive to the point that we're not able to keep our plans because it gets in the way. And then compulsions also have themes. So there can be the decontamination rituals, hand washing, bleach wipes, and again, it's excessive. We're not just washing our hands one time to make sure they're clean. Maybe we're doing it 15 times, and now it's to the point that our hands are bleeding because we've scrubbed them so hard. The checking, did I lock the door, right? And maybe we've locked the door and it's unlock, lock, unlock, lock, unlock, lock, over and over a certain amount of times before we believe it's locked. Hoarding. Sometimes after a loved one dies, people think that they need to keep all the person's things in order to preserve the memories of them. Now, this doesn't meet the diagnostic criteria for hoarding disorder, but we're just keeping more things than we need, most of the time tied to someone that has left or passed. The counting. If I count to 10, this bad thing won't happen. Arranging and rearranging things. Oftentimes that's what we see maybe portrayed on TV most, where things need to be arranged in a certain way. All the labels on cans facing out, or all the pencils in line. Using prayers or chants to prevent bad things from happening. And this can be verbally or silent in their head. And then rituals to ward off superstitious things like having lucky numbers versus unlucky numbers. So I always think it's helpful to hear from someone who has experienced it. So let's make sure we do that. And so this woman is going to kind of describe how her experience with OCD has impacted her.
I know it's illogical. Objectively, I know nothing bad is going to happen, but I still can't stop. Hi, my name is Rachel. I'm a video producer. I'm an imperfect environmentalist. I love animals, I love cooking, and I have obsessive compulsive disorder. If I could describe OCD in one word, it would be exhausting. OCD can look really different for a lot of people. I feel like there's kind of this preconceived notion that OCD is someone who washes their hands a lot and they need everything to be super neat and tidy and organized, but that's just not the case for everybody who has OCD. It can be intrusive thoughts, like maybe when you're driving your car, you're afraid you're just going to suddenly swerve into oncoming traffic. There are different types of checking compulsions. There's contamination OCD, really hot right now, and many other types as well. So my OCD started around when I was 8 or 9 years old, and it really started with a fear of bad things happening to the people I loved. So if my mom was late from getting home from work, or my dad was flying for a business trip, I would have to touch objects around the house until it felt right. And the risk was, if I didn't do it, my mom would get into a car accident or my dad's plane would crash, and then it would be my fault. I used to ask my mom for reassurance constantly, which is a very common OCD compulsion. For instance, if we were cooking together and I accidentally touched a piece of food while I was stirring a pot, I would ask her if it was okay, and I needed to hear her say it was, otherwise I thought I could poison my whole family. I used to assign significance to different numbers, so 2 was bad, 3 was good, 5 meant death. It's so strange hearing myself talk about it out loud because it's like, what does that even mean?
So yeah, so a lot of the things that she shared are what we were just, kind of learning about, all the different ways that this can impact someone's life. And it isn't only about things being in order or, colors all together, which absolutely can be part of it, but it's so much bigger than that. And really that's what it's portrayed as in media. And so that's why often we think that that's what OCD is, the hand washing or the ordering of things. So before we move on, I'm going to open up the chat. Hop into the chat and let me know if any of this kind of came as a surprise. Did you just learn that there's so many different aspects of some of these compulsive behaviors? Did you think it was just kind of the ordering, the having things in order and washing of the hands, or did you know more about it? So let me know. Are there things that came as a surprise, or are you well versed in OCD? So I'd love to hear that. Because it's really common. We only see really in TV and media, the ordering and cleaning. We don't see much more. So the numbers and assigning numbers as good and bad is new for a lot of people. Yeah. For some people, no surprises. And they could just really relate to the video. So someone asked if someone has one of the criteria, would it be OCD? And so no, they have to meet all of the diagnostic criteria for it to be a diagnosis. Now, I always like to point out, just because you don't meet the diagnostic criteria doesn't mean you can't get help. Right? So if you're having symptoms that are causing distress or impairing your ability to function, go get help. You don't have to meet that diagnostic criteria. Some people didn't know about, kind of thoughts of death. Yes, that can be part of it as well. So what do compulsions without obsessions look like? And it's more about kind of having a lot of rules. And so, I wake up, it's almost like you can assign, like, for example, from this video, you can assign numbers to be good or bad, but there's no intrusive thoughts about it, right? It's only good if I wake up on an even number and I go to sleep on an even number. So there's nothing being assigned to it. It's not, I'll keep breathing if I do this, or my family will be okay if I do this. It's just that this is what I do. This is a very rigid rule. And again, it's excessive and it's impacting someone's ability to function and oftentimes causing a lot of distress. Thanks so much for sharing in the chat. I always love to know kind of what pieces were helpful and new, and also what we were already kind of experts in. Would a daily checklist be considered part of OCD? It can be, but not necessarily, right? We often talk about coping here, or being able, in our webinars, or being able to meet goals by having checklists that get us through a day and helps us to stay focused. I make checklists so I know what I need to get done in a day. So it doesn't necessarily mean that the person has OCD. Some people pointed out that they were surprised by that constant reassurance. Absolutely. That's a big one too. All right, so let's talk about cause, risk factors, as well as co-occurring conditions, and then how prevalent this disorder is. So we don't fully understand what causes the disorder, and right, this isn't new. I think majority of the time that we meet for webinar, my answer is we don't know the exact cause. It is hard to study the brain. It's hard to research mental disorders, and there's been a lot of stigma attached to it, right? And so research in general is behind. But so there's some main theories. So there's biology, genetics, learning, and then pandas. And let's go over each of those. So research does suggest that OCD involves communication problems in the brain. Communication problems are between the front of the brain and then the deeper structures. And these brain structures use serotonin, which is a chemical messenger, to communicate. Pictures of the brain show that in people with OCD, and again, this is only some people, their brain circuits work better with medications that affect serotonin levels. So oftentimes when I share information like this, people ask, well, then why can't we just be doing, pictures of the brain for everyone to determine if they have OCD or not? And it's just not that simple, because we don't see the exact same thing in everyone. Right, like we would see maybe if we were taking blood for some kind of disorder or an X-ray. And then research shows that OCD does run in families. Genes likely play a role in the development of OCD, but scientists really believe that they're only partly responsible. Can be something that is learned. A painful childhood experience, trauma, abuse, bullying can lead to learning to use obsessions and compulsions to cope with the anxiety. And in cases where parents have similar anxieties and showed similar kinds of compulsive behavior, their children sometimes learn to use obsessions and compulsions as a coping technique. And then there's PANDAS, and this is short for pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. So a child can be diagnosed with PANDAS when OCD, a tic disorder, both start after an infection, a streptococcal infection like strep throat or scarlet fever. It also can be diagnosed when sudden, rapid onset of obsessive compulsive behaviors. And so symptoms are usually pretty dramatic and happen overnight and out of the blue. And again, this is just with PANDAS, not any other form of OCD. And it can include movement or vocal tics or both, and then obsessions or compulsions or both. Children may become irritable, moody, have anxiety attacks, and suddenly be afraid of being away from their parents or loved ones. Most kids who have PANDAS recover completely with treatment. The doctor will treat the strep infection with antibiotics, and then therapy can help with the OCD type symptoms. So then what is increasing our risk of developing OCD? So there's a couple different factors in developing or maybe triggering, right? So we may have those biological genetic components, but it isn't until something happens that the disorder is triggered. So we may have a predisposition towards it, and then something needs to trigger it. And we know family history, parents or other family members with OCD can increase your risk of developing it. But it may be stressful life events that trigger it. Stress, trauma can cause those intrusive thoughts to start, as well as the compulsions or rituals. So if you experience stressful or traumatic things, your risk does go up. And then other mental health disorders. OCD may be related to other mental health disorders like anxiety, depression, and substance abuse. Anytime you've already had one mental disorder, it does increase the risk of having another. Now, how prevalent is it? Approximately 2.3% of the population has OCD, which is about 1 in 40 adults and 1 in 100 children in the United States. In families with a history of OCD, there's a 25% chance that another immediate family member will develop it. Average age of onset of OCD is 19 and a half years old. Males make up the majority of very early onset cases, almost about 25%. of males have onsets before age 10. Most females are diagnosed after the age of 10. And then co-occurring addiction. So a lot of people asked about this in the Q&A. 90% of adults with OCD at some point in their lives also have another mental disorder. So examples that we may see along with OCD are 75.8% anxiety disorders, including panic disorders, phobias, and PTSD. 63.3% have mood disorders like major depressive disorder and bipolar disorder. Nearly 60% have impulse control disorders like ADHD. And then 38.6% have substance use disorders. So with these high number of co-occurring disorders and not really knowing the exact cause, what does treatment look like? Well, we'll talk about that next. Before we do that, let me just check a few more of your questions. Do all people with hoarding disorder have OCD? No. So a symptom can be the hoarding of things. It does not mean that they have a hoarding disorder when it comes to OCD. Now, there are people that have OCD and hoarding disorder at the same time. Can someone with narcissistic personality disorder also have OCD? And that is possible. Can it co-occur with schizophrenia? Sure. Can you age out of OCD? And no, it can impact people at any age, and it can be something that's lifelong if treatment isn't participated in. Are there any disorders that prevent OCD? So there's no disorder that's going to prevent it from happening. Going through some of the questions. All right, so we got lots of people asking about how you go about getting a diagnosis. So let's talk about that. So if we are noticing that there are symptoms causing distress, we have intrusive thoughts, behaviors, compulsions attached to it. And intrusive thoughts don't necessarily mean it's OCD, right? We do see intrusive thoughts within anxiety as well. So if you're having symptoms, go talk with a professional. Right? You don't have to wait until you meet this diagnostic criteria to go get help. Really, the way to possibly prevent having a disorder is to get help early on for symptoms that are bothering you. And so you can start with your primary doctor if that's where you feel comfortable, or you can go right to a psychiatrist, a therapist to talk about the symptoms you're having, and one, to receive treatment, but two, to get a diagnosis. So then there's treatment approaches. So two main treatments for OCD are therapy and then medications. Often treatment's most effective when it's a combination of both. So OCD treatment doesn't cure the illness, but it can help bring symptoms under control so that they don't rule a person's life. So really what we're looking here is a reduction in severity and frequency. And there are people that their symptoms are under control and they're not having any of those symptoms. When we're talking about therapy, most often used is cognitive behavioral therapy. This is effective for many people with OCD. It's really kind of teaching us different ways of coping, because like we mentioned, right? Oftentimes OCD can be kind of started with us doing these things as a way to try to cope with the difficult feelings. And so learning new ways of coping and different ways of thinking and behaving is a big part of treating OCD. ERP, which is exposure and response prevention, involves gradually exposing the person to a thing that they fear or have obsessions about and learning ways to resist the urge to do the compulsive rituals. ERP takes effort and takes practice, but it can lead to better quality of life. Now, certain psychiatric medications can help control obsessions and compulsions. Most commonly, antidepressants are tried first. And so scientists aren't sure exactly how these particular medications are helping OCD. But the good news is that after decades of research, we now know how to treat patients, even though maybe we don't fully understand why the treatment works. But what is known is that antidepressants affect serotonin, and serotonin is used by the brain as a messenger. If the brain doesn't have enough serotonin, then the nerves in the brain aren't communicating properly. Antidepressants can help boost serotonin levels and get the brain back on track. All right, so lastly, we're going to talk about managing symptoms as well as helping others. Before we do that, let me just answer a few more questions. All right, so someone asked, what's the difference between OCD and obsessive compulsive personality disorder? So they're two completely different disorders. Obsessive compulsive personality disorder is just that, a personality disorder. And it is really about kind of having some very kind of rigid behaviors, right? So working very late hours, wanting everything in a specific way, done in a specific way, being able to control how things are done. It's not really about the intrusive thoughts or the behaviors trying to reduce the intrusive thoughts, so the compulsions. It's really just more about a personality that is, very kind of strict, controlling, and wants things done in a very specific way. They're very, oftentimes very work focused, and it impacts their ability to have relationships. People with obsessive compulsive disorder, like we're talking about today, most of the time, the majority of the time, are aware that they have this disorder and don't like it, don't benefit from it, and wish they didn't have it. People with obsessive compulsive personality disorder very often aren't even aware that they have this disorder. It's just part of their personality. It's how they've always been, and they see nothing wrong with it. What role does age play in kind of like the frequency and severity of symptoms? Um, it, it really varies, right? So it's kind of on a continuum where someone may have more mild symptoms, someone may have more severe, and they can move kind of back and forth on that continuum. But it isn't always really related to age. It's really related to how they know how to cope, what their stressors are. Can stress increase OCD symptoms? And it absolutely can. Oftentimes, like we mentioned, OCD is used in an attempt to, these obsessions and compulsions are used in an attempt to try to cope with some very difficult feelings or anxieties. If we have more stress, we more likely will turn to those obsessions and compulsions to try to feel better. What can we do if someone's afraid to take medication? A lot of times it's about education, so finding out what it is that they're fearful of, and they don't have to, right? They can try therapy alone. Sometimes it's educating them on how it would be helpful and how they'd benefit from it. Are numbers always part of OCD? And no, lots of people don't connect numbers with it. It's just one of the many different themes. All right, great questions. So now let's talk about managing symptoms. So if you yourself have symptoms, what you can do in addition to treatment, and then we'll talk about ways of helping others. So for people with OCD, we want to learn more about it. Learning about OCD can really be empowering and often motivates people to stick to their treatment plan. And so that treatment plan is what you're going to be creating with a therapist, with a psychiatrist, and we want to stick with it. Right? Oftentimes when people start to feel better, they stop going to therapy, they stop taking their medication, when in reality, that's what made them feel better. So we want to stick with that treatment plan. And part of that treatment plan is going to be goals. And so we want to stay focused on the goals. And remember that recovery is this ongoing process. It doesn't happen overnight. And something that can be helpful to remind yourself of is that anything that changes overnight can go back overnight. And so it is going to take some time to start to feel better. Joining a support group can be pretty important. Connecting to other people who are experiencing the same things can be a good source of support. Want to focus on your health, try different things to channel energy, hobbies, doing things that are fun, physical activity. Want to take good care of ourselves, right? So we're getting that physical activity in every day. We're eating healthy food, so we have good nutrients to feed our brain. And make sure you're getting enough sleep, 6 to 9 hours, 7 to 9 hours a night. Want to learn to relax, manage stress. Now, there are a lot of different types of stress management techniques to help manage the stress and anxiety. Going to therapy, your therapist will teach you many of them, and then you need to practice it outside of therapy. This could be things like meditation, yoga, visualization exercises, massage, deep breathing, Tai Chi. Then you want to stick with regular activities. Make sure you're going to work or school as you usually would, whenever possible. Spend time with family and friends. Get out there and do things you enjoy. And we're following that treatment plan, like I mentioned, right? So your psychiatrist and your therapist are going to create this treatment plan. Now, obsessive compulsive disorder is a chronic condition, which means it may always be part of your life. While OCD warrants treatment by a professional, there's lots of things that you can do to build on that treatment plan. So we're practicing what we're learning in therapy. Work with your therapist to identify techniques to manage OCD symptoms and then practice them outside of therapy regularly. We want to make them a habit so that way they're already there when you need it. Make sure you're taking your medication as directed. Even if you're feeling well, resist the urge to stop your medication. If you've been in treatment for a while, you feel like you don't need the medication, talk with your prescriber first before going off the medication, or maybe you don't like how the medication makes you feel. Talk with your prescriber before you ever go off the medication. You just don't want to stop suddenly. It can make you feel pretty sick. Start to pay attention to warning signs. Contact your doctor or therapist if or when you notice changes in symptoms or how you feel. Make a plan so you know what to do if your symptoms increase. And then check first before you take other medications, right? We had questions about herbs and supplements in the Q&A, and there's no solid research that's been done that provides evidence that herbs and supplements treat OCD, but you can do the research on your own. You can talk with your doctor, but make sure you're talking with your doctor before you take anything, especially if you're already on other medications. Now, how do we support a loved one that has OCD? So we're going to want to become educated on OCD. Want to learn to recognize and reduce accommodation behaviors and learn strategies about how to respond if your family member is refusing treatment. Now, often our loved ones feel isolated, feel frustrated, they feel shame, maybe some guilt. And there is often a feeling of not knowing what to do. So educate yourself. As you learn more about OCD, you'll be better prepared to support your loved one. So you can read books, you can join the International OCD Foundation, which has chapters or affiliates around that you could try to join, find the one that's closest to you, and attend support groups. If there are support groups specifically for OCD, there's support groups for the loved ones of someone who has OCD, or there's support groups for the loved ones of someone who has a mental disorder, that we can get support from people that fully understand and that are going through what you're going through. Then we want to work on recognizing and then reducing the behaviors that we have that accommodate their OCD. So friends and family often give in to unreasonable demands because their loved one is so unhappy and because they themselves feel so powerless over the symptoms. So examples of these accommodation behaviors could be facilitating symptomatic behaviors or rituals. So buying excessive amounts of cleaning products for our loved ones so they can be over cleaning their space, or providing extra storage space for them to hoard their cleaning products or hoard other things. Maybe you've been changing the family rituals. Maybe you're changing the time of day that you shower, or you're changing your clothes in the garage to accommodate your family members' OCD preferences. Maybe you've been modifying activities or schedules, right? Agreeing to not have company come over this Friday because it interrupts their ritual. So if the person's refusing treatment, we want to do a few things: bring information on OCD into the home, encourage them, discuss the ways in which we have been accommodating the OCD, like we just talked about, and then suggesting the person attend support groups. So we can bring in books, articles, other information that your family member can read. We can offer it to them, or maybe we did a search on the family computer and we just left it up for them to find. Want to give some encouragement, right? Assure your loved one that with treatment, most people are better. The severity and frequency of their symptoms really becomes sometimes non-existent. There is help available, and there are others with the same problems. You're going to want to discuss how you've been accommodating their OCD behaviors, just like we learned about in the last slide. Explain how you've been accommodating the illness and why it's not helpful. So that way your loved one knows you're trying to stop accommodating as a way to be a better support person, not out of spite, right? So we're going to, once we identify how we've been accommodating it, we let them know, and we also let them know that it's going to be stopping. And then suggest the person with OCD attend a support group, right? So just like there's support groups for you, there's support groups for them. And if they're afraid to go alone, you can always go with them, sit out in the car, in the hall, but supporting them and getting there. And then as a loved one, you want to take care of yourself. So you can seek out professional advice. If you're struggling to cope with your loved one's mental disorder, their OCD, you can talk with a doctor or mental health professional yourself. Again, you don't have to have symptoms or meet the diagnostic criteria before you can go to therapy. Find support for yourself. Connecting with other people who are in similar situations is a good source of support. So this could be friends and relatives that are experiencing it, joining those support groups. Surround yourself with people that can give you the support that you need. Now, here are some additional resources. We got some support groups, some recommended reading. And we'll make sure all of this is in that email we send out tomorrow, and also in the chat for you. And that's the same with our crisis resource guide. So if you, someone you know, are in crisis, need some support, need someone to talk to, someone waiting to receive your call or your text, listen to what you have to say, provide some support, and offer options and resources. All of this will be in that email we send out tomorrow. Find links in the chat for you now. And here are upcoming webinars. For anyone that does not know or forgot, tomorrow's Wednesday, and Wednesday is double feature day. So in the morning, we're going to be talking about understanding personality disorders. We had a lot of people ask about personality disorders in relation to OCD, so that would be a great one to join in on. And then later is cannabis and mental health. So if you haven't registered for those, it's not too late. We'll put the link to register for both for tomorrow in that chat for you. We'll provide a link in that email we send out tomorrow, and then we'll give you the overall link so you can register for all of them. So take a look at your at this list of upcoming webinars, and while you do that, I'm going to answer a couple more questions. All right, so someone brought up asking if I said that people that know that they have OCD and wish they didn't. So great question. Let me kind of clarify. Many people know that, or I would say most people know that they have these symptoms. Not everyone knows that it is obsessive compulsive disorder, right? So when I was talking about obsessive compulsive disorder versus obsessive compulsive personality disorder, it looks like maybe I misspoke in that people with OCD are aware of the symptoms. Maybe they don't know what the diagnosis would be, but they're aware that the symptoms are there and that they are troubling. Someone with obsessive compulsive personality disorder does not notice that these symptoms are happening of that personality disorder, and oftentimes it doesn't cause them any kind of distress. So someone asked who can make a diagnosis, a psychiatrist or psychologist, and both. So psychiatrists are doctors, they're medical doctors that specialize in mental disorders and prescribing medication for them. Psychologists are like therapists. There's many different types of therapists where they get their degree and licensure in. So social workers can be therapists, marriage and family counselors, psychologists, there's a lot, and they can all make a diagnosis as well. So what if family doesn't know anything about OCD and they're not interested in learning on their own? So if you have OCD yourself, you can educate them if you want to, or provide opportunities for them to learn. But you're allowed to say, you know what, it's not my responsibility to have to teach you this, and encourage them to learn more on their own. Are symptoms only a certain time of the day or throughout the day? And it is typically throughout the day. So someone brought up the accommodating behaviors, and when it comes to reassurance, and how do we navigate not giving so much reassurance without being unkind? So one, if they're in therapy, we need to work with a therapist. How are we going to do this? But another thing is you can sit down with the person that has OCD and let them know, right? The continual reassurance is going to be accommodating behaviors and making things worse. So let's make a plan. Now, it's best to be doing this when they're in treatment, so they have something to replace it with, right? So we're thinking of that reassurance as a way of trying to cope. We need to replace it with a different coping mechanism. But we can talk with them and say, okay, I can only give reassurance this many times a day. And so, right, maybe 5 times a day. And so, especially if it's much higher, right? So maybe you pay attention, the two of you pay attention how often they ask for reassurance, and we start to lessen it and how much we can give. And so it's like, all right, this is your first reassurance check. You only have 4 more, 3 more. And so then they also need to be learning, though, other ways of coping with the feelings or thoughts that they're having. Now, if you need any additional resources, head on over to our website, mindspringhealth.org. You can find us on social media at Facebook, TikTok, and Instagram at Mindspring Info, or on LinkedIn at Mindspring Mental Health Alliance. You can also send us an email at info@mindspringhealth.org. And then let's go over our frequently asked questions in case you missed it in the beginning. This has been recorded, and everyone who registered for today's webinar will receive an email tomorrow with a link to the recording in it. Also in that email will be all of the resources we talked about today. No slides will be sent out, and CEUs are not provided for community education webinars. Now, what we do provide are certificates of attendance once you've completed the post-webinar survey. My goal is for everyone to leave here feeling like they learned something, and that survey lets me know if we reach that goal. The organizations that are supporting our webinars want to know how their donations are used and what communities participate. This data is randomized, it's confidential, no one's demographic information is shared. So everyone who registered for today's webinar and joined the live session will receive an email from certificates@mindspringhealth.org soon after the webinar ends. Complete the survey within 48 hours to receive your certificate. Now, even if you don't want a certificate of attendance, we'd love for you to complete the survey. Your participation helps us to continue to offer free webinars. Thanks so much for joining me. It was great talking with all of you, and hopefully I get to see you again tomorrow twice. Bye.